This recording will go over anti-seizure medications. First thing we want to think about is, what does it mean when a seizure occurs? With a seizure, we have too much firing of neurons within the brain. So too many neurons firing at the same time, and anti-seizure drugs make it harder for that uncontrolled wave of firing to begin or to spread. Anti-seizure medications work in 3 different ways. They can suppress sodium influx, suppress calcium influx, or enhance the action of GABA, which is an inhibitory or calming signal in the brain. So by working in one of those 3 ways, anti-seizure medications can help to prevent seizures or stop seizures. So if an anti-seizure medication works on the central nervous system, the brain, to decrease activity, decrease firing going on in the brain, what might you think you'd see in the patient? If we're turning down the brain, what might you see in the patient? So when taking medications for seizures that are going to slow down firing, calm things down, you want to watch for drowsiness, dizziness, slowed thinking, poor coordination. Those would all be expected with anti-seizure medications. It's important to think about, though, because you as the nurse are going to want to think about fall risks for this patient, driving safety, if they're on any other sort of CNS depressants, whether opioids or any other medications, or if they drink alcohol, because combining CNS depressants would make that drowsiness and poor coordination, everything that goes along with that, even worse. So combining CNS depressants is something we'd want to watch for. One of the medications we're going to talk about is phenytoin. And how does it work? It limits rapid neuron firing by blocking sodium channels. So it stabilizes the neuron, so repeated electrical firing is less likely to spread. Some things to watch for that could indicate toxicity include nystagmus, ataxia, dizziness, drowsiness, confusion, poor coordination. A patient who suddenly has abnormal eye movements, that nystagmus, slurred speech, or an unsteady gait could be showing signs of toxicity, so it's something we would want to assess. A long-term effect could be that gingival hyperplasia. So think of gingivitis as your gums, right? Hyperplasia is excessive growth, so gingival hyperplasia. For that patient, for all patients on phenytoin, we want to make sure they are practicing good oral hygiene and seeing a dentist on a regular basis. Thirdly, cardiovascular effects are especially important with IV administration. Rapid administration of phenytoin can produce hypotension and dysrhythmias. And we also want to assess mood and watch for suicidal ideations for a patient taking phenytoin. A rare but serious adverse effect is purple glove syndrome. It occurs with local tissue injury associated with IV phenytoin. So inspect the IV site and extremity for pain, swelling, and discoloration. The therapeutic serum value for phenytoin is 10 to 20. And what you need to know is if the patient's blood level is below that therapeutic serum level, so in this case below 10, the patient would be at increased risk for seizures. If the patient's blood level is above the therapeutic serum concentration, the patient would be at increased risk for toxicity. Phenytoin is a highly protein-bound medication. Therefore, a decrease in serum protein or albumin can increase the free phenytoin serum level and increase the risk for toxicity. Phenytoin is contraindicated for use during pregnancy because it can have a teratogenic effect on the fetus. Phenytoin has many drug interactions, including antacids, calcium products, sucralfate. They can all interfere with absorption, so timing matters with medications. Other medications can increase or decrease phenytoin concentrations, and phenytoin can alter the effects of anticoagulants. Think of your anticoagulant that is highly protein bound, and hormonal contraceptives. When obtaining a health history in a patient who takes phenytoin or is about to be prescribed phenytoin, make sure you ask about prescribed drugs, including and also over-the-counter medications. Ask about antacids, supplements, herbs, alcohol use, pregnancy, and adherence or recently missed doses. Review seizure frequency and whether the pattern of seizures have changed. Assess the patient's gait, coordination, speech, eye movement, level of consciousness, oral health, and the IV site when applicable. In terms of looking at labs, we want to look and see if we have any renal or hepatic dysfunction, which could affect how the medication is metabolized and excreted. We want to look at albumin levels because remember, albumin's a protein and phenytoin's highly protein bound. So if we have low amounts of albumin, we'll have more free phenytoin, which could raise the serum level of the medication. Assess for sedation, dizziness, ataxia, and assess for fall risks and if there's an immediate threat to the patient's safety. The nurse will want to monitor the ordered serum levels and confirm when it is drawn. A trough is generally collected immediately before the next dose. You want to also assess the patient, watch for seizure activity, nystagmus, speech, gait, cognition issues, monitor vital signs, and watch for signs of adverse effect. Use seizure and fall precautions when indicated. And during initiation or dose adjustment, patients should avoid driving or hazardous activity until they know how the medication affects them and how they will be able to meet driving requirements. Phenytoin can reduce the effectiveness of hormonal contraceptives, and we had already said it is not recommended for women who plan on becoming pregnant or are pregnant because it can harm the fetus. So the nurse should be sure that the patient receives individualized counseling from the prescriber or pharmacist and understands the need for reliable contraception when pregnancy is not desired. The next classification we're going to talk about is barbiturates. Phenobarbital is your prototype medication for barbiturates. You'll notice that it has the barb within it to help you remember that it is a barbiturate. It can suppress seizure activities effectively, but the same CNS depression that helps control seizures can also cause significant safety concerns. Phenobarbital works by enhancing GABA activity. We said that's that inhibitory or calming signal. Connect that mechanism with sedation, slowed thinking, impaired coordination, respiratory depression, and additive effects with alcohol, opioids, other benzoids, or other sedatives. In terms of what you will want to focus on, when we know that we're going to be slowing and turning things down, we're going to monitor the respiratory rate, oxygenation, BP, level of consciousness, and of course be watching for falls with this patient. Therapeutic value for this medication is 15 to 40. So again, if we're below the therapeutic value, we would worry about seizures. And if we're above the therapeutic value, we would worry about toxicity. With continued use, tolerance and physical dependence can develop. So we want to discontinue the medication gradually. Abrupt withdrawal of the medication could trigger seizures or status epilepticus. The next classification is succinimides, and the prototype medication is ethosuximide. Ethosuximide is used to treat absence seizures. It works by reducing the calcium currents that are involved in the rhythmic activity associated with absence seizures. You might see a patient with absent seizures who just stops talking and stares blankly for several seconds and then resumes activity without realizing anything has happened. Sometimes there might be a subtle eye fluttering, but it's not the dramatic seizure, tonic-clonic activity that you would see in the movies, or that many people associate with seizure activity. The therapeutic serum level for ethosuximide is 40 to 100. We already know if it's too low, we worry about seizures. If it's too high, we worry about toxicity. We want to monitor the patient for side effects and adverse effects, including GI upset, fatigue, dizziness, headache, all pretty common. More serious, the things that we'll watch for include blood dyscrasias, lupus-like reactions, serious skin reactions, psychosis, or suicidal ideation. We want to have the patient monitor for a fever, sore throat, unusual bruising, bleeding or rash, or any behavioral changes. And we're going to monitor CBCs and liver and renal function as well for the patient on the medication. Next up are the benzodiazepines, your PAMs and LAMs, and clorazepate. Not every benzo on the slide is used in exactly the same way. Clonazepam and clorazepate can be part of ongoing treatment for selected seizure disorders, while diazepam is emphasized for rapid rescue treatment for emergency situations such as status epilepticus. Benzos work by enhancing GABA-mediated inhibition. So remember, GABA is that calming inhibitory signal. They work quickly, but can cause, you already know, sedation, hypotension, respiratory depression, falls, tolerance, dependency, and withdrawal symptoms. The risk increases when combined with other CNS depressants or sedatives, such as opioids, alcohol, or barbiturates. Why isn't diazepam just the medication we give patients with seizures? While diazepam rapidly, it has a relatively short anti-seizure duration after redistribution. So that's why longer acting anti-seizure medications are administered during or soon after rescue treatment to help prevent recurrence. So while diazepam, the benzo, can work quickly for a patient that's having a seizure or in status epilepticus, we ultimately want to get those maintenance medications like phenytoin on board, get the patient therapeutic with those meds. During an emergency administration, make sure that you're maintaining the patient's airway, providing oxygen, suction is needed, monitoring respiration rate, oxygen saturation, BP, cardiac rhythms, level of consciousness, and how the patient responds to the medication. The next classification is aminostilbenes. Your prototype is carbamazepine, which works by blocking sodium channels in the brain to stabilize overactive neurons and prevent rapid, repetitive electrical signals. Therapeutic range is 4 to 12. So if it's low, we're at risk for seizures. If it's high, we're at risk for toxicity. Carbamazepine can cause problems with blood counts. So we want to monitor for leukopenia, agranulocytosis, anemia. We're going to be looking at the CBCs. Additionally, we want to be watching for liver function, and we want to tell the patient to report any fever, sore throat, unusual bruising, jaundice, rash, blistering, or mucosal lesions. Valproic acid can be used for many different types of seizures. Common side effects include GI distress, drowsiness, dizziness, tremor, weakness, and weight change. Serious side effects include hepatotoxicity, so toxic to the liver, pancreatitis, thrombocytopenia, and bleeding. During pregnancy, both uncontrolled seizures and medication exposure can create risks. So the pregnant woman will work with her provider to find the safest, effective treatment for good seizure control. Remember, many seizure drugs are teratogenic or can cause damage to the fetus, and many anti-seizure drugs tend to inhibit vitamin K, which could contribute to infant hemorrhage after birth. Also, anti-seizure drugs increase the loss of folate in pregnant patients, so they'll need daily supplements. Remember, we can see seizures with pediatrics, and it's usually associated with a fast, high rise of a temperature. They can be scary, but they're usually brief with excellent prognosis. And lastly, but very important, is the emergency, medical emergency of status epilepticus, which would be a seizure that doesn't stop or occurs back to back with no time for recovery, and it can result in death. So the primary treatment for status epilepticus would be a benzo, so diazepam, lorazepam. And we would follow that with a loading dose of phenytoin to get up the serum levels, and then get the patient on a maintenance dose. We're going to be monitoring for respiratory depression and the patient being treated for status epilepticus.